We begin with a 78-year-old male presenting in the clinic with progressive disorientation. Over the past year, he has exhibited apathy, mild agitation, and a documented decline in memory recall and executive function. The diagnostic profile points to suspected early Alzheimer's disease. However, the presence of visual hallucinations and apathy introduces features of dementia with Lewy bodies. His chart also notes two systemic comorbidities, hypertension and mild renal impairment. FDA guidelines explicitly approve the use of donepezil across the entire spectrum of Alzheimer's disease, from mild to severe stages. Beyond Alzheimer's, donepezil is strongly recommended for dementia with Lewy bodies. Clinical data shows it reliably decreases the frequency of delusions, apathy, agitation, and visual hallucinations in these specific patients. Donepezil operates as a selective, reversible, and non-competitive acetylcholinesterase inhibitor. Achieving baseline cognitive stabilization in this patient requires a highly targeted neurochemical intervention. The drug must exert its effects centrally in the brain without triggering systemic reactions that would exacerbate his existing hypertension or renal impairment. To understand how donepezil achieves this, we have to look at the microscopic level of the neocortex, specifically focusing on the cholinergic neurons that regulate memory and are actively degenerating. Look at this animated diagram of a synaptic cleft. Under baseline pathological conditions, acetylcholine molecules are released into the synapse but are rapidly degraded by the acetylcholinesterase enzyme, severely limiting neurotransmitter availability. Donepezil intervenes centrally. It binds to the acetylcholinesterase enzyme, physically blocking the degradation process. With the enzyme inhibited, acetylcholine is forced to accumulate, increasing its availability in the synapse to compensate for the dying neurons. What distinguishes donepezil from older agents like rivastigmine is its high specificity. It selectively targets acetylcholinesterase while completely ignoring butyrylcholinesterase. Pharmacologically, a strict threshold dictates clinical efficacy. Cognitive improvement is entirely dependent on achieving greater than 65% inhibition of the acetylcholinesterase enzyme. To reach this threshold safely, the initial therapeutic protocol for our patient starts at 5 mg per day, administered at night. While this targeted inhibition successfully masks the loss of cholinergic neurons, it is strictly a symptomatic delay. The underlying neurodegenerative pathology continues to advance. Fast forward 4 to 6 weeks. Protocol dictates escalating the patient's daily dose to 10 mg. The rationale for this delayed titration is strict toxicity management. Slow escalation effectively mitigates predictable cholinergic side effects caused by excess stimulation, primarily nausea, diarrhea, vomiting, and appetite loss. Donepezil is characterized by an exceptionally long elimination half-life. It takes roughly 70 hours to clear oral formulations and up to 91 hours for the transdermal patch, which allows for stable, once-daily dosing. Donepezil undergoes extensive hepatic metabolism via the cytochrome P450 system, heavily reliant on CYP3A4. CYP inhibitors like ketoconazole or fluoxetine block clearance, dangerously elevating plasma levels and toxicity risk. Conversely, CYP inducers like rifampicin or alcohol accelerate metabolism, dropping plasma levels below the therapeutic threshold, eliminating efficacy. The combination of a 70-hour half-life and strict CYP450 dependency means maintaining the patient within the narrow therapeutic window requires rigorous pharmacological surveillance. When adverse effects do occur, we must differentiate between central and peripheral symptoms. Because donepezil is highly active in the central nervous system, it frequently induces sleep disturbances, abnormal dreams, and extrapyramidal symptoms. Despite its potent central activity, donepezil carries an anticholinergic effect on cognition score of exactly 0. This stylized medical graphic of an ECG highlights the peripheral threat. Severe cholinergic excess carries notable cardiovascular risks. French pharmacovigilance data reveals that donepezil induces bradycardia in 10% of cases, widespread weakness in 5%, and convulsions in 4%. Clinicians must avoid combining donepezil with beta blockers, amiodarone, or calcium channel blockers. These combinations have an additive effect on cardiac conduction that can induce severe heart block. Caution is equally mandatory with any agents known to prolong the QTC interval. Surgical anesthetics present another systemic hazard. Donepezil exerts a synergistic effect with depolarizing neuromuscular blockers like succinylcholine, dangerously amplifying their paralytic effect while simultaneously antagonizing competitive blockers. The clinical mandate is absolute. Donepezil must be completely discontinued prior to any surgical intervention. Preventing lethal toxicity is an ongoing calculation. The targeted cognitive benefits in the central nervous system must continually be weighed against the inevitable and potentially fatal vagal stimulation in the periphery. Returning to our clinical timeline, the patient's underlying Alzheimer's inevitably progresses from the early stages to moderate to severe disease. The 10 mg dose is no longer sufficient. This chart comparing 10 mg and 23 mg doses illustrates the escalation dilemma. High-dose monotherapy yields a minor 2.2-point cognitive improvement, failing to improve global functioning. The trade-off is poor. It triggers a threefold increase in gastrointestinal side effects, jumping from 5.9% to 21%. Transdermal patches, such as Adlarity, offer an alternative delivery method, but require strict adherence. They must be refrigerated, applied exactly once a week, rotated across sites every 14 days, and monitored for allergic contact dermatitis. Rather than pushing high-dose monotherapy, the optimal intervention is Namzaric, a fixed-dose combination of Donepezil and memantine. Clinical data proves this combination delivers superior outcomes for global assessment, daily activities, and neuropsychiatric symptoms. Because our patient is already stabilized on 10 mg of Donepezil, the Namzaric initiation protocol starts at 7 mg of memantine combined with 10 mg of Donepezil, increasing the memantine dosage in 7 mg increments each week. As neurodegeneration outpaces the capacity of a single drug, utilizing synergistic mechanisms through combination therapy maximizes functional preservation without amplifying dose-dependent toxicity. The case enters its final stage. The patient's Alzheimer's progresses to severe, with his MMSE score dropping as low as 3. This triggers a standard clinical debate. Is there any value in continuing medication when cognition is nearly gone? The definitive protocol for profound cognitive decline is dictated by the Domino-AD trial. This line graph tracking cognitive decline illustrates the trial's exact findings. Continuing Donepezil treatment is directly associated with sustained cognitive benefits, even in patients operating at the absolute lowest thresholds of the MMSE scale. The most critical metric is socioeconomic. Withdrawing Donepezil during moderate to severe disease drastically accelerates the loss of independence, significantly increasing the risk of nursing home placement within 12 months. Therefore, aggressive maintenance therapy is statistically mandated. Keeping the patient on the drug is the most effective method for preserving autonomy and delaying institutionalization. Reviewing the patient's intake chart one last time, we addressed his baseline mild renal impairment. Because only 17% of Donepezil is excreted unchanged in the urine, renal clearance rates are functionally unaffected. Standard dosing is maintained with no adjustment required. If clinical circumstances ever force the cessation of Donepezil, the drug must be tapered gradually over weeks. Abrupt discontinuation initiates a profound withdrawal syndrome. The sudden drop in acetylcholine availability triggers a precipitous and severe deterioration in both memory and behavioral stability. This rapid functional loss is highly destructive. Even if Donepezil is quickly restarted, the cognitive baseline lost during the withdrawal period frequently fails to fully restore. By successfully escalating to Namzaric, meticulously avoiding contraindicated CYP inhibitors, and committing to indefinite maintenance therapy, the clinical team holds the line. They balance neurochemical enhancement against the relentless advance of progressive pathology.